Hello, this is video number 3 on the respiratory anatomy, and in this video we will be discussing part C on the outline, gross anatomy of the lungs, blood supply to the lungs, and a topic that leads into the respiratory physiology, which is how the lungs stay inflated. All right, this slide is showing gross anatomy of the lungs, position of the lungs, and the thoracic cavity. They're well protected by the rib cage and the sternum. The lungs are basically triangular in shape, I guess you could say. They have a relatively wide base, and they come to a point. So that's the base. The point is called the apex. The apex pokes up through the top of the rib cage, and another thing you should notice is the relative size of the right lung versus the left lung. The left lung is a little bit smaller, and that's because this space here is taken up by the position of the heart. Heart is mostly to the left of the midline. Okay. One other feature I forgot to mention is the base rests on the diaphragm. This slide is looking at a cross-section through the thoracic cavity at the level just superior to the heart. And so this allows us to see some of the tubes, vessels, air tubes, that are gathered together and enter into the heart at a common position. So these tubes, the main bronchus, pulmonary artery, pulmonary veins, gather together, and they're called the root of the lung. And where they enter is an indentation on the medial surface of the lung called the hilum. The root of the lung is located at the hilum, and that's seen on both the right and the left side. The slide also illustrates the serous membranes in the thoracic cavity. The lungs are surrounded by the pleural membranes. Serous membranes always come in pairs. There's a visceral pleural membrane that coats the entire surface of the lung, and it conforms to all the indentations and the grooves on the lung surface. So that's the red stripe shown on this slide. The parietal pleural membrane, shown as a blue stripe, that adheres to the body wall. So that's true for the posterior surface of the lung, the lateral surface, the anterior surface, but when you get to the medial surface, the parietal pleural membrane is in contact with the pericardial membrane. That's where the lungs come up against the heart. Okay, this slide is showing the surfaces of the lungs. This would be lateral at the top, medial surface at the bottom. The medial surface shows the root of the lung. All of the tubes gather together here, entering at the hilum. So that's the indentation. The lateral surface illustrates some of the main differences between the right and the left lung. And those are, first of all, right lung is larger, as I mentioned before. And the left lungs, being smaller, has a sort of an indentation on the medial inferior surface called the cardiac notch. The right lung also has 3 lobes, whereas the left lung is divided only into 2 lobes. Lobes are basically sectors of the lung. They're sectored off due to a partition, connective tissue partition, between these different areas. All right, within lobes, there's further subdivision into segments. And these are color-coded by different colors on this slide. So if we're looking at the right lung here, this is different segments of the superior lobe of the right lung. And that's true also for the other lobes as well. The segments can be further subdivided into what are called lobules. So there's basically a hierarchy of Sectoring, I guess you could say, of lung chambers from the lung itself to the lobes, to the segments, to the lobules. All right. Another topic related to the anatomy of the lungs is circulation to and from the lungs. The lungs have two main types of circulation serving them. One we've just discussed extensively before for the chapter on the heart, and that's the pulmonary circulation. The pulmonary circulation, shown in this slide, takes blood from the right ventricle, oxygen-poor blood, to the pulmonary trunk, to the pulmonary arteries. Those arteries are going to deliver blood to the pulmonary capillaries that are surrounding the alveoli. That's where the blood is going to pick up oxygen. It's going to circulate away into the pulmonary venules and eventually to the pulmonary veins, returning blood back to the left atrium. That's the pulmonary circulation. Pulmonary arteries carrying deoxygenated blood, pulmonary veins carrying oxygen-rich blood. Right, the bronchial circulation, and this is my highly technical drawing of the bronchial circulation. The bronchial circulation is a branch of the systemic circuit. It has bronchial arteries, which are carrying blood. Bronchial arteries here branch off of the aorta. They're carrying oxygen-rich blood into the lungs. And this oxygen-rich blood is going to supply the cells of the wall of the bronchi and the bronchioles. It's delivering oxygen and nutrients to those cells. Blood draining from the lungs in the bronchial circulation enters into the bronchial veins. And this is where it gets a little bit unusual. For most tissues, the veins draining the tissue will eventually merge with the inferior or superior vena cava and be delivered back to the heart. But for the bronchial veins, they actually merge with the pulmonary veins. So there's a little bit of mixing of oxygen poor and oxygen rich blood. The pulmonary veins, as you know, will return blood from both types of circulation, pulmonary and bronchial, back to the left atrium. All right, next topic is part C on the outline, which is why do the lungs remain inflated? And think back to an earlier video in which I mentioned that there's extensive elastic fibers within the lungs. And those elastic fibers have the tendency of wanting to contract if there's no other force acting on them. So this slide is showing that in the lung tissue, the lung tends to want to contract on itself, and it's showing arrows pulling the lung away from the body wall, but this would be in general happening on all surfaces of the lung, tending to want to shrink the size of the lung. So this is at the bottom labeled as the elastic recoil of the lung. That's pulling away from the body wall. On the other hand, the body wall, which includes the rib cage and the thorax and the musculature, that wants to expand. And that can be seen in thoracic surgery. Opening of the thoracic cavity causes kind of a movement away, expansion of the thoracic cavity. You may have seen this as well when you've done dissections of cat or the mink. When you cut through the rib cage and open up the thoracic cavity, the walls of the cavity expand outward. All right, so there are two opposing forces. The thoracic wall tends to want to expand, move outward, and the lungs want to contract in on themselves. They're pulling against each other. The lung doesn't collapse, even though there is this force tending to pull it in on itself. And the reason why it doesn't collapse is because there's a fluid seal in the pleural cavity, the serous fluid. that's preventing the surface of the lungs from pulling away from the inside of the body wall. Okay. Now, that creates a difference in pressure, and you can measure the pressure, two different pressures actually. The pressure of the air that's inside the lungs, and that's called the intrapulmonary pressure, within the lungs pressure, and the pressure that's present in the fluid, the serous fluid, in the pleural cavity. That's called the intrapleural pressure, within the pleural cavity pressure. Okay. Because, going back to the previous slide, because there's this pull of the lungs inward and the pull of the body wall outward, the intrapleural pressure is slightly lower. There's a slight vacuum in there. Intrapleural pressure is about -3 millimeters of mercury compared to the intrapulmonary pressure, air pressure within the lungs. Okay, so that slight negative pressure in the intrapleural cavity, the pleural cavity, excuse me, is what's keeping the surface of the lungs adhered to the inside of the body wall. Now, the importance of that in keeping your lungs expanded can be seen when this fluid seal is broken. And that can happen in certain injuries. Oh, sorry, I forgot that this slide is also showing what was shown on the previous slide. Intrapleural pressure, and in this case it's saying -4 compared to the intrapulmonary pressure. And this is also giving the actual values. At air pressure, 760 millimeters of mercury, compared to intrapleural pressure, 756, so a slight vacuum in the pleural cavity. Now, what happens if we break the fluid seal because of the serous fluid causing the outside of the lungs to adhere to the inside body wall? So that's what happens in the situation called a pneumothorax. A pneumothorax literally means pneumo, air, in the thorax, and it's actually air that's been introduced into the pleural cavity. Air can be introduced into the pleural cavity either by some kind of injury from the outside, so a puncture to the thoracic body wall. That could be due to some kind of, some kind of injury, which, let's say, a puncture due to a stick poking into the rib cage, or a knife wound also can be such an injury. In such an injury, that introduces air, and that allows air to fill the pleural cavity and allows the lung to collapse upon itself. So a pneumothorax will cause a collapsed lung. A pneumothorax can also be caused by a broken rib, for example, that can puncture this seal, and also any kind of lung disease that causes a puncture in the external surface of the lung, allowing air to escape from inside the lungs into the pleural cavity. In addition to the pneumothorax, which we just discussed, there are a couple of other types of lung disorders that are related that I wanted to mention. One is an atelectasis. An atelectasis causes a collapse of the lung. It can be the whole lung or a part of the lung, such as a lobe or a segment within the lung. And unlike a pneumothorax, this is due to some internal condition. For example, when we talked about respiratory distress syndrome in prematurely born infants, there's a lack of surfactant. And you remember the surfactant prevents alveoli from collapsing in on themselves. So the lack of surfactant can cause a number of nearby alveoli to collapse, and that will cause a collapse of a lobule or a segment or a lobe of the lung, and that's an atelectasis. Another condition which can arise is called a pleural effusion. Pleural effusion is due to collection of fluid in the pleural cavity. Like I mentioned, there is serous fluid, usually not very much though. If there's some other source which allows a lot of fluid to collect, that can crowd the space of the lungs and their ability to expand when you inhale. So one of the main symptoms of pleural effusion is a shortness of breath because of the limiting expansion of the lungs. Pleural effusion is usually due to some type of disease, pneumonia, for example, that can cause excess fluid to gather in that space. All right, I'm going to end this video here, and the next videos will start talking about respiratory physiology.